We're thrilled to have the latest insights on tinnitus from this world-leading group of neurological researchers. So we're just introducing the panel discussion, and if you would like to make your way to your seat now, that would be great. Thank you. Our panel chair is Alan Baddock, and he will introduce the panel in a moment and then discuss the neuroscience of tinnitus. Alan is a screenwriter, director and journalist with over 30 years experience in developing documentaries for international and local audiences, including 100 or more science, public issues and natural history films for broadcast here and around the world. Please join me in welcoming Alan.
Thank you, Annabelle. Thanks, Annabelle. As Annabelle said, our three panelists have had a busy week in Auckland at the International Tinnitus Conference. So we're grateful for your time today. Thanks for joining us. I'd just like to introduce our three panelists. On the far left, we have Professor Dirk de Ridder, who holds the position of the inaugural Neurological Foundation Chair of Neurosurgery at the University of Otago. Formerly a neurosurgeon at Antwerp University Hospital, one of the Belgium's leading hospitals. He founded and directed a brain research centre there and a tinnitus research initiative. Then in 2013, Professor de Ridder began his joint University of Otago and Southern District Health Board role. He's based with the university's Department of Surgical Sciences as head of New Zealand's first academic neurosurgery unit. He now spends 50% of his time as a neurosurgeon at Dunedin Hospital and 50% of his time on research and teaching. Next to me is Professor Deb Hall, is the director of the Nottingham Hearing Biomedical Research Unit of Britain's National Institute for Health Research. She's also Professor in Hearing Sciences at the University of Nottingham School of Medicine. And Professor Hall has an honours degree in psychology from Brunel in London and a PhD in cognitive neuropsychology from the University of Birmingham. She spent over 12 years at the MRC Institute of Hearing Research in Nottingham, where she developed some of the world's first methods for neuroimaging to study how the brain processes sound. She's published over 70 peer-reviewed papers and is the section editor for the international journal Hearing Research. Professor Hall's current primary research goals are to understand the mechanisms of tinnitus and the plasticity of our sensory neural systems following hearing loss. And I'll ask her shortly to talk about what sensory neural systems are. She's also working to develop an evidence base for effective tinnitus management strategies. And then our third panellist in the centre is Dr. Grant Searchfield, who's head of audiology at the School of Auckland Health, School of Population Health at the University of Auckland. He also directs the university's hearing and tinnitus clinic. Dr. Searchfield's work has emphasised research into the clinical assessment and management of tinnitus based on new understanding of brain mechanisms. And some of his work involves collaboration across many groups in the University of Auckland Centre for Brain Research, and that work aims to develop novel sensory-based methods to help people with tinnitus to recover. And Dr. Searchfield has a strong profile in tinnitus research internationally and has been the chair of the 2014 Tinnitus Research Initiative Conference. So, thank you for your time, folks, and I'll fire some questions at you, but feel free to range as widely and moving from our previous speaker as excitedly as you feel inclined. We're here to highlight Brain Day and to stimulate thinking about the things that affect our brains and the things that our brains affect. In many ways, this is a journey of discovery that we're just beginning, and for me it's probably the most exciting of all journeys of discovery. I'm not too concerned about the outer space. The real frontier, I think, is our inner space and understanding our inner space. So on that note, I'd like to ask Dirk, what is the brain from a scientist's perspective? And what does it do? How do you see it?
Well, that's of course the million-dollar question, and if we can answer that, we can probably solve a lot more pathologies and diseases. From an evolutionary point of view, we've probably developed a brain to predict what's going to be around in the environment whenever you start moving around. So there is a little animal called the sea squirt, and the sea squirt swims around in the sea, and when it at a certain moment in life it stops its moving around and it goes and sits on a rock, and then it doesn't move anymore. On the moment that it goes and sits on the rock, it basically digests its own nervous system, which is the spinal cord and the central ganglion. And based on this concept, Rodolfo Llinas, who's both a neurologist and a zoologist, has suggested that actually we have a brain, because when we start moving around in the environment, we need to be able to predict what statistical patterns that come back. So basically what your brain wants to know is, behind this rock, is there food, is there a partner, is there a predator that's going to devour me? So by being able to predict what's going to be behind the corner, it increases your chances of survival. So from this point of view, our brain is basically a prediction machine that tries, based on what is stored in memory, and this is probably why we have a memory, to be able to predict what's going to be what we're going to encounter next, and based on this, you try to reduce the inherent uncertainty, which is there a predator, is there a partner, is there food, and this will help us in order to survive. So it's a tool from an evolutionary perspective that we developed to increase our survival chances.
So Grant, then picking up from that, can you relate that to tinnitus?
Well, very much so. I think that one of the first things that people with tinnitus will often do is go searching for where the sound is coming from. So if you wake up in the morning and you're hearing the sound around you that's annoying, you go looking for it, and often it's when the sound can't be identified as coming from something in our environment that it actually becomes a problem. Just to give an example, client came to see me, said that for quite a while during the summer he was aware of the cicada that was following him around the house, and he really wasn't bothered by it at that particular time. It was summer, there were lots of cicadas in the environment. He was somewhat perplexed that they seemed to be more around at this time of year than normally, but when he was out fishing, there was a little tinny there, and he realised the sound was there, and there were no cicadas in that environment. This is when it actually changed from being something that was perhaps fairly normal or of the real world versus something that was very difficult to predict and was unusual and was from the inner self. So this relationship of looking for something causing the sound is very important, I think, into changing tinnitus from a sound into tinnitus being a sound with an annoyance related to it.
So what is tinnitus and what causes it?
Yeah, well, tinnitus broadly speaking is sound somewhere in the head that's not caused by an external sound, but perhaps we can demonstrate what tinnitus is by asking the audience. I mean, how many people in the audience actually believe that they have tinnitus? Okay, all right, now how many people hear a buzzing sound? Okay, how many people hear a hissing sound? Okay. How many people hear crickets? Cicadas? All right, tones? All right, now how many people hear it in more on one side of the head than another? Okay, and how many people feel it fills their head? Okay, how many people hear it as, honey, you need to do the dishes? Okay, right, well that last one's not tinnitus, but all the other ones, all right, all the other ones actually are. So that perhaps illustrates that there's a huge amount of variability in what we term as tinnitus. So it's a catch-all phrase for sounds that are heard that aren't actually created by an external object around us.
Now, yes, I was just picking up on that because actually there are two types of tinnitus you identify, isn't there?
Well, there are a number of ways to cut this problem up into different categories. For a long time, tinnitus was categorised as being objective tinnitus. That is a tinnitus that someone else could actually hear, which is much rarer, and subjective tinnitus, or true tinnitus, which is what most people experience, where another person can't actually hear it. So the objective tinnitus is often caused by sound somewhere created by movement or blood flow within the head neck region, and that's the sort of thing that often a surgeon might be able to correct, but that's much rarer than what most people experience, which doesn't have an external sound source.
Cool. So that brings us to you, Deb, in terms of your speciality is neuroimaging, that allows us to study how the brain processes sound.
That's correct.
And so, how does the brain process sound, and what role does that have in tinnitus?
Okay. Well, a lot of my work has been looking at how the brain processes external sounds, and you may know that what sounds are physically in the environment are changes in pressure waves, so vibrations in the air that reach our ears, and our ears have very, very sensitive sense organs, little hairs that vibrate with the pressure reaching them from the external wave. If they vibrate slowly, then it indicates a low frequency, low pitched kind of sound. If they vibrate quickly, it indicates a high pitched sound. And so the ear converts these vibrations into electrical messages that go up to the ear. So go up to the brain. Now, the fascinating thing and the challenge for us as hearing scientists is that the only information that the ear sends to the brain is the information about the frequency of the sound, so is it low or high pitched, and information about how loud the sound is. Is it a very soft sound, or is it a very loud sound? And that's encoded in the number of electrical messages or electrical impulses that get transmitted to the brain. So the challenge for the auditory brain is to work out from this information everything about the external world around us so that we can interact with the world in the way that Dirk said. So we need to be able to work out where or what a sound is. If I'm talking to you, I need to kind of separate out your sound, your voice voice from the background noise. I want to work out where you're sitting. Are you here or are you over there? I want to work out what it is about you. Are you a man or a woman? And what do I know about you? Can I recognise you? What is it that you're saying? And all of that information is the role of the brain. So the brain has to interpret from the messages that it gets to the ears exactly what is in the external world around us.
So how do you study that?
There are a couple of main techniques in how we study it. The first branch of science is the concern of psychologists, or perceptual psychologists, who are interested in understanding how we can manipulate very abstract information about sound and look at how it affects performance. And from those measures of performance, we can work out or infer how the brain processes sound. So we can manipulate the information in the signals coming from the ears in terms of, say, the timing of the information from the two ears, the frequency of the information, and that tells us how the brain deals with these cues. Another way, which is the way that I conduct a lot of my research, is with brain imaging. So we have a number of different techniques that have been developed over the last 20 years or so that enable us to indirectly measure the activity that's going on in somebody's head when they're listening to sounds. We have electrical-based methods, where we put a cap with lots of sensors that can measure the underlying electrical activity in the brain. And we have MRI, which is another technique that's actually measuring very, very tiny changes in the blood flow within the brain that or happen within the brain whenever a particular part of the brain is active. So if a part of your auditory brain is active, then there'll be more blood flow goes to that part of the brain to enable that part to do its job. And we can measure those very small changes in an MRI scanner and analyse them and generate pictures so that we know which parts of the brain are processing what kind of information. So those are the two main methods.
So I know when I first became aware of tinnitus, I had the impression it was a disorder of the ear, but I'm getting the impression that thinking has shifted from that idea, and from what you're saying, the focus has shifted now. Dirk, if you...
Yeah. So, well, I'm a brain surgeon. Just the fact that I'm involved in tinnitus research probably suggests that it's not only the ear, otherwise I would be in a completely wrong part of the business. So initially people were indeed focusing on the ear as the sole responsible cause for tinnitus, and then it started shifting to the idea that actually it's the auditory system going from the ear to the auditory cortex. And now we're also realizing it's not just the auditory cortex, it's actually the entire brain. So there is, for example, at least two important separable pathways that are involved, and one pathway predominantly processes the characteristics of the sound. How loud is it? Where is it located? How do you perceive it? Is it noise-like? Is it tone-like? And then on the other hand, there is a system which is not specific for tinnitus, which is more encoding the affective components. How are you? How bothersome is it? How unpleasant it is? And these systems are separable, and we know that already for a long time. In the 1930s, when frontal lobotomies were popular, they would do cingulotomy. So they would cut, they would make a lesion in the frontal part of the brain where the affective component was processed, and people would say, yeah, I still have the tinnitus. It's exactly the same as before, but it doesn't bother me anymore. So which means that that these are probably separable systems, and the one system is of course influencing the other one. And we're now also starting to realize there's, just like in pain, you've got pathways that bring a pain signal. So if you tap your finger with a hammer, there is at least two pathways which are similar to the ones in the auditory system, where one just says, well, the pain is located in the finger, it's sharp pain, it feels so intense, and the other one says, well, the pain is unpleasant. And then there is also a pain system that suppresses the amount of pain. So it's like a car where you can accelerate and have a brake, and you can say, well, you can have a car and you just with an accelerator, but the problem is if you want to stop, you have to lift the accelerator, and it takes a while before you stop. So you also need a brake, and this brake is a system that then suppresses the pain, and in the sound system probably something similar is present. And so now we're also starting to realize that tinnitus is maybe a balance between input and the amount of suppression, and that we can start to try and influence both systems. First, we have to understand these systems better, because especially there's not been a lot of research going on this break on the auditory system, but by better understanding it, actually we can develop better treatments in the future.
So, what do we know now then about the causes of tinnitus, or the cures? Because I'm picking that probably most people in this room are, while they're fascinated by the neuroscience of tinnitus, their primary interest is what can you fix, what can you do about it? So can we perhaps just work along and just develop what insight we can into the causes, but more particularly where this is going?
Do you want to start?
That's fine. So I start at the top, and Grant starts at the ear and works his way up. So this is already to start saying that actually the best treatment for tinnitus is multidisciplinary, because I know nothing about the ear. I know a little bit about its process further up in the brain, and so you need to collaborate with multiple people together. Some people are more specialized, like psychologists, in taking into account the affective components associated with tinnitus. Somebody who knows how to deal with hearing problems, which are probably the most common cause of tinnitus. So if you look at tinnitus, you have to, from a practical point of view in the clinic, you have to make a separation. And as we've heard before, there used to be the separation, which still exists, between objective and subjective, but you can also start from a practical point of view. You can ask the patient, well, what does it sound like? It's your heartbeat or your respiration on the one hand, or like a typewriter machine, or on the other hand, does it sound like a more constant sound, which already separates how you look for a cause, because the best treatment for tinnitus is still, if you can find a cause, then treat a cause and see if you can thereby get rid, which surprisingly is not always the case. So sometimes you can find a cause, treat it, and still the sound might persist. And this is then caused by some brain mechanism, not in the ear. So if you have hearing loss, the hearing aid will not work all the time, and this is of course where it's important to then see if you can find a reason why. So after you've made this decision, which kind of tinnitus is it, whether it's rather pulsatile or non-pulsatile, and then if you go to the pulsatile group, in general, in about 80 to 85% of the cases, you can find a solution, and 15% we still haven't got a clue. And if you can find them, then you can treat them. For example, if you have abnormal blood vessels in your brain, you can try to correct those. If you have an increased pressure in your brain, which is the most common cause for this kind of tinnitus, then you can try to decrease the pressure in your brain. So there's lots of causes that can be found and treated. On the other hand, if it's non-pulsatile, then most of the time it's related to hearing loss, and then of course for me, I will first refer those patients to somebody like Grant, who's an audiologist, and can better take care of that than myself. But from a brain point of view, you want to know, is it associated with another symptom? Does the patient who have tinnitus also have a headache? Because that will then cluster certain diseases that have both tinnitus and headache. Does the patient have associated vertigo? Is the patient's head spinning? That then clusters, and there is a couple of diseases that have those in common. And so depending on the associated symptom, you can try to figure out a cause which can sometimes, but not always, be treated. If you can treat the cause, of course that's better. If you cannot, then you have to go to a more symptomatic approach. So the audiologist will of course help with every kind of sound treatment, and I'm sure Grant will be able to talk about that better. If that doesn't work, then you can say, well, maybe the psychologist should help if it's very bothersome in trying to help the affective component with it. And if that doesn't help enough, you can sometimes use medication, predominantly if the tinnitus is very bothersome. For example, if it's present or dominantly present for 80% of the time in the day, then when patients can't concentrate anymore, can't function very well, then sometimes medication can help, predominantly in reducing the amount of time that people are focusing on it. However, and I'm sure Deb will talk about that, we don't have a lot of evidence for it. Which causes some kind of problem. But we have to consider that even though there is no evidence that it will work, that should not defer you from trying a treatment, because there cannot be evidence for a couple of reasons. First, it hasn't been studied, and then of course you don't know, or it hasn't been studied in a proper way, and this is where Deb's work is very important, because she helps clinical researchers like Ron and myself in designing better ways of studying it, so that we can ensure that what we're measuring is actually correct. And so then you can say, well, the medication doesn't work, what other options do we have? And the other options might then be neuromodulation, which means you try to change activity in the brain which we know from imaging research, such as the one that Deb is doing, that where we can try and modulate brain activity with external stimulation, magnetic or electrical stimulation, with neurofeedback, which tries to normalize the brain activity. And if that doesn't help, well, then you're a little bit at the end of the road, and then there is unfortunately only one option is say, well, I've tried everything. Is there somewhere some research going on that might be beneficial or not? So depending on, so there is not that you go to audiologist, psychologist, or ENT surgeon, or the neurologist or the neurosurgeon and say, I've got tinnitus, and he will prescribe you a pill and the problem will be solved.
So Grant, you're working in a clinical situation. So what's your approach? I mean, taking what Dirk has just outlined, like, how does this work in practice?
Well, people will come and see us, of course, and they say they have tinnitus, and they want to know initially what the cause of this was and whether it can be treated. And one way of viewing tinnitus is that we can talk about subaudible tinnitus and audible tinnitus. And there's a view that, and there's some evidence that if a person doesn't have tinnitus and you put them in a quiet enough environment, they will hear some sort of sound in their head or ear, so that's subaudible. And it's an injury or change which then makes us audible in some way. Now, we know from population statistics and self-report in clinics that the most common associated cause for tinnitus is noise-induced hearing loss, so damage from exposure to sound. And in the majority of cases, tinnitus will in some way be associated with a hearing loss. Now, obviously the hearing loss is coming from damage to the ear. It doesn't mean, as we've talked about, that the sound itself, the tinnitus sound, comes from the ear, but somewhere the brain is trying to compensate for this lack of activity. We also know that a number of people will come to see us who say that they've had the sound in the ears for a while, but something else has happened, a stressful life event, that has actually changed that tinnitus and has made it more audible, more noticeable, and has had a greater effect. So this is where we have what, at the face of it, might seem a hearing-related problem, an audiological problem. Fix the hearing, and hopefully the tinnitus will then subside, to also the more psychological component with how we're actually feeling or coping with the tinnitus. And I think that as research is going on, while once we thought about it as being a hearing problem, and then we saw that the reaction was very important, now it's become very difficult to say the separation between these two and pulling these sorts of things out. So in a clinical situation, when people come and see us, we talk to them about their tinnitus. We try and find out as much as possible that we can about the nature of the sound that they hear, what it might be caused, do hearing tests, look at the health of the ear, and this helps us decide potentially whether we need to refer on for assistance to one of these other fields that might be working. For example, if they're having pulsatile tinnitus, we want to refer on to a physician to actually have a look at that. It's relatively easy for audiologists when that tinnitus is associated with a hearing loss, and then in a majority of cases, if we fit hearing aids, then the tinnitus can be less noticeable. Right? And this can be effective in the majority. So that's the number one tool in our toolkit, is hearing aids. If they have a certain amount of hearing loss or tinnitus is of a particular nature, then we will potentially introduce other sounds into the environment. And at a basic level, we often talk about sound therapy, and this is very much a catch-all phrase, or the way I use it is anyway, which incorporates the use of sound for any particular manner to try and reduce tinnitus. And it can be as simple as avoiding a quiet room, even though ultimately what people desire is silence and to get away from tinnitus. But by seeking solitude and quiet, that really feeds the tinnitus. It's what tinnitus wants. It has no competition. So in order to drive down tinnitus, you need competition.
So in that, are you suggesting, I mean, is it just simply a case of putting other noise in the brain so you don't hear the ringing, or is there a response from whatever the phenomenon is causing tinnitus?
Okay. Well, and that's a good question. I think that we would like to think that we're very sophisticated in how we're using sound, and there are a number of theory-based sound therapies, so they're based on a particular mechanism that has been postulated to occur in the brain causing tinnitus, and so they've been designed to actually focus on that. For example, to reduce an abnormal volume control within the brain, to try and turn down the excitability of the brain, or to reduce how particular neurons are firing together, to disrupt that in certain ways. But some of our evidence to describe which and the way that these are actually working is somewhat crude. And I think that we could probably say reasonably comfortably that sound helps. It may simply help from a distraction and a competition point of view, or it may be actually having some longer term changes in the brain. For example, one of the things is when I first arrived here, I grabbed a coffee. That's an aside, by the way, the coffee. But I went into the museum shop, and when I entered there, by the door, there were little devices that made sounds. They project fancy pictures onto the ceiling and things, but they make nature sounds. And I'm not employed by the museum at all, but you can actually buy these for $30 at the museum shop. And they're good if you happen to be at home, or you're trying to get to sleep and you just are focused on your tinnitus sound and you haven't learned a way of tuning out of that tinnitus, then having some other sound going on in the environment can help. So it's a very simple way of trying to reduce the contrast between tinnitus and other sounds. Just to give a simple example is that if you are in a dark room and you light a candle, the candle is very bright. And if we say for a moment that candle represents tinnitus, all right? It's like tinnitus when we're going to sleep. There's not a lot of competition. Very difficult to ignore the candle. The candle flickers, our attention is drawn to that. But if it's the middle of the day and we have the curtains drawn back, we're busy doing the other things, the candle can be there. The candle is bright as what it was before, but we don't notice it so much. So this is a contrast effect. And in very simple terms, this may be the most basic way in which sound is actually helping us.
So is this what your research is indicating, Deb? You're finding that actually the tinnitus doesn't change, it's just our awareness of it that we can play with?
So this is one of the questions that our research is currently focused on. I have to say at the moment we still don't understand the simple answer to that question, Alan. We know that a lot of people find hearing aids and other sound therapies beneficial. Some people might find them less beneficial, and some of the work that we are currently conducting is to try and ask the question about who finds the sound therapies beneficial, and also to try and understand whether the sorts of things that might be going on in tinnitus that can be alleviated or benefited by sound therapies might be around the brain changing the way that it deals with sound information through having these therapies, or whether it's something that's a bit more of a a kind of secondary benefit of a hearing aid. For example, being able to hear better and hear the auditory world around you just might simply mean that you're focusing much less on your tinnitus, you're much less aware of it. Obviously, our hope is that these therapies are actually changing the way that the brain processes sound, so that they might be actually changing and reducing the initial cause of the tinnitus, rather than just reducing our awareness of the symptoms. But this is still a question. It'll keep me in a job for the next 20 years, I think, to try and find the answer.
This leads me on, because the thing I was going to ask, which I suspect I know the answer to, and I suspect you've also indicated, but like, how close are we to a cure? How close are we to finding an understanding of tinnitus that enables us to actually, cure the cause and take it away, rather than just hiding it behind other sound?
I think that the simple answer to that question, from my own personal point of view, is that we will never find a cure for all of tinnitus. As Dirk alluded, there are lots of different causes for tinnitus. So although I think about 80% of people might experience a tinnitus primarily through some degree of hearing loss, age-related or noise-induced hearing loss, there are lots of other people who experience tinnitus for other reasons. So finding one single cure that will help everybody who experiences this awful sound, I think is very unlikely. But what we hope that over the next few years is that we'll understand more about different causes of tinnitus, and how those different causes actually change the way that the brain kind of deals with information and generates that phantom sound, that sound that we hear. That understanding those different groups of people with tinnitus and what the different causes are will help us tailor specific treatments that will be effective for those different subgroups. So that's what a lot of research is now focused on, is trying to identify these different subtypes of tinnitus, and that will then explore us being able to identify and tailor individual treatments that will be most effective for a particular person's tinnitus.
Now Dirk, you mentioned before neuromodulation, and I know you work with neurostimulation. Is this the sort of thing we're talking about, where you actually have procedures that work to directly affect the brain's responses?
Yes, that's the purpose of it. And so, as mentioned before, initially most research was focusing on the ear, and then people said, well, hearing aids will solve the problem and there will be one cure for everybody. Then we realized it doesn't work. So then we started thinking, well, it's the auditory system. So then we said, well, if it's the auditory system, we will find one cure for all. We just we stimulate the auditory cortex, either through the skin and the skull with magnetic stimulation or electrical stimulation, or even with implants, and we'll find a cure for all. And that showed that it didn't work for all. So then we realized that actually it's more, like Deb said, it's more like cancer, where there is not one treatment for all cancers, but some cancers can be better controlled than others, and they all have different treatments. So neuromodulation is one of these ways. So if we understand better what is the difference, for example, between people who have hearing loss as the cause of tinnitus and people who have no hearing loss. And what we've recently been looking at is that the ones without hearing loss, it might be more of an auditory cortex problem, that the auditory cortex is behaving in an abnormal way, and that we should maybe focus there. Whereas in the people where it's related to a hearing loss, it might be more in an area that is actually more related to memory. So as I started off by saying, a brain predicts what's going to arrive from the environment. Now, if your brain has constantly had input from all frequencies, or all, then when you lose one, for example, when you become older, you tend to lose the high frequencies. Your brain says, yeah, but normally these high frequencies should arrive as well. And if you can't perceive them, then the brain can do two things. Either it can try to be more sensitive, so you become sensitive to sounds because it just tries to pick up those high frequencies as well. And if it really can't get get it because there is no input, the hair cells are completely gone, then it has to resort to what it can, which is probably memory. So, well, I've got something stored from before, and then it fills it in with a sound. But that sound then hypothetically comes from memory, so in those patients you might have to actually try and modulate this memory pathway rather than the auditory cortex. So a neuromodulation tries then to be more selective. So you can, in treating either, let's say the cortex or the parahippocampus, but maybe even better might be to modulate the communication between two areas, because ultimately activity in the brain is one aspect, but what is more important is how do different parts of the brain communicate, and then if we can try to modulate or change the communication, actually that might show to be more powerful. So we're now developing a system that is able to uncouple different frequencies in order to disrupt this communication, because if the brain predicts this sound should arrive, then it goes and measures the error of that prediction, and if there is a big error, it will fill it in from memory. And so maybe if we can manipulate, take away the prediction or reduce the error, then the brain cannot answer in a correct way, but it does so by communicating between different areas. So if we can change this communication, then we might develop a new treatment.
And so by neuromodulation, you're talking about actually using electrodes or some technique to actually break the signal moving between the ear and the brain.
And so you can basically divide it in two categories. One is the non-invasive neuromodulation, which entails transcranial magnetic stimulation. So you use magnetic pulses in order to change the activity or the connectivity. And the second,
just putting some sort of magnetic signal on the outside of the brain.
Outside, yeah, and it gives pulses that you feel like little pulses on your skin. Then the second is the transcranial electrical stimulation, where you can use different kinds of electricity. So it can be direct current, which is basically like a car battery. You can use alternating current, which is what you use for light. You can use random noise stimulation, and then within random noise you can use white noise, pink noise, black noise. So there's lots of different kinds of current that you can use to change this activity and this connectivity.
So how are you using the current? What do you actually do to actually...
Just like with a car battery, you have a positive pole.
Stick a wire on each side of the head. And
yeah, well, we don't stick it in there in the non-invasive. We just put it on top.
Yeah.
So you've got the magnetic, you've got the electrical, and then another way of modulating brain activity is by neurofeedback. Neurofeedback, what you do there, and there has been a recent developing to doing three-dimensional neurofeedback. Basically, you look in the brain where you find abnormal activity or connectivity. You say, well, this area I want to change, and people just look at the screen. When they look at the screen, they can have any kind of feedback, which could be a red light, a green light, a movie that stops. And then you say, well, the activity should be like that in between these ranges, or the connectivity should be like that within these ranges. And then when the activity is out of that good range, they get a negative feedback, which could be a red light. And then when the activity is within the good range, they get a green light. And the brain learns how to train itself to get within the right activity. So these are basically the three ways of non-invasive neuromodulation. And then there is also invasive, and this is what I, as a surgeon, of course, am interested in, is how can we go inside the brain with electrodes and implant areas to normalize, just like they do in Parkinson's disease or in pain treatment. And we've tried that at multiple areas. We've tried it at the frontal cortex, at the auditory cortex, at memory areas, now also at the cingulate area. So you can, and the reason why you have to do that is only, of course, if nothing else helps, and it is very, very handicapping. But the invasive neurostimulation is just an extension, basically, of the non-invasive. And the question could be, well, why would you ever go to invasive? The reason is relatively simple. Non-invasive stimulation has a short-lasting effect. So either you have, for example, let's say you respond to direct current stimulation on the frontal cortex, it can last for let's say 3 weeks. After 2 weeks of stimulation, of course, you cannot go for the rest of your life for 2 weeks stimulation, and 2 weeks you're better, and then again. So then, if you see that has a good effect, then you assume that by implanting the system, basically, that you can have a longer term effect. So these are the different kinds of neuromodulation.
So Grant, then, I mean, this is the high-tech, cutting-edge, research end. How many of these techniques are available to people in the ordinary course of treating tinnitus?
Well, I guess the decision is made about when it should be introduced as a treatment. Dirk's been talking about the electrical stimulation, and this is something that we've been doing some research on as well. And what we have been debating is that we can get short-term benefits within the clinic using this, but it is very, very short-term. So it's not really a treatment. It's a way of changing how the brain is, and it's very interesting from a research perspective. However, if a person is particularly bothered by the tinnitus, it does give them a period of time when they might not experience it, or experience it not quite as badly. So one of the debates that we have is at what level of efficacy does something turn from something experimental into something that's treatment. Now, tinnitus is rife with all sorts of wacky solutions. You only have to go onto the internet and you will find lots of cures for tinnitus, which is great. Of course, none of them actually work, which is not great. And everything that you try and doesn't work is negative to the individual experiencing it, because you build your hopes up and then those get dashed down. So translating research into clinical practice can take quite a while. It can be quite frustrating for people, because they hear these new ideas but they're not seeing them in practice. It's a difficult thing. Many of them could be implemented relatively easy because they're safe. Non-invasive, as it sounds, is non-invasive. It's fairly safe. There are some criteria that have to be checked off before you can have these sorts of treatments. Certainly in those sorts of things that really are an evolution of existing therapies, for example, with hearing aids or sound therapies, the technology develops, our understanding develops, it evolves, it gets a little bit incrementally better. It's very easy to implement those sorts of things. But where there is a big change and the evidence is not good yet for a long-term change, it takes a while to introduce, and this is something that the Deb's group in the UK has been exploring with a number of different therapies, and probably in particular in relationship to the national health within the UK, as to when it becomes a viable treatment and when it is a cost-effective therapy to actually introduce. And there's always this tension between introducing something that might work for some people but we don't know who it will work for, versus people that are wanting to have a solution, and we're just concerned that when we try things and they don't work, that it can be very deflating. And so finding this balance is very difficult.
Yeah. So Deb, what is looking most promising in your research currently, if you're looking at these different therapies?
So the whole process of evaluating whether therapies are kind of really effective for a large number of people with tinnitus is actually very time consuming. So to run, just to give you an example, I mean, to run a trial, we're hoping to run a trial on hearing aids to show how beneficial hearing aids are for people with tinnitus. Now, I mean, you might say, why are you starting there when hearing aids are already offered? Well, they are already offered routinely in clinical practice, that's true, but audiologists don't know kind of how the best way of fitting the hearing aids are, who might benefit most in terms of their tinnitus. And certainly in the UK, we found for people who have a very mild degree of hearing loss, where, for example, a hearing aid might not normally be offered because the person only has a mild loss and can still hear sounds relatively well. There might still be a big benefit for those people who have tinnitus and a mild hearing loss, but the audiologists don't have any evidence or any information to help guide their recommendations to individual patients. So that's the way that we're trying to go at the minute, to help the NHS make the most of the resources that they've got and the most of the current treatments, to make sure that those current treatments that we know work well in some people, to make sure that we can use them effectively for everybody who has tinnitus. Now, to answer that question is a sort of 5 or 10 year research program in itself, and we're just embarking on that journey.
So you're saying it's a 5 or 10 year program from here just to establish the effectiveness of hearing aids?
To answer the question fully about when hearing aids are most beneficial, what sort of amplification strategy might be most beneficial? What about a hearing aid that just amplifies sound, or a new kind of hearing aid that's a combination device that helps people hear better but also delivers a masking sound that can help reduce the awareness of people's tinnitus? There are lots of questions around hearing aid devices that I think, to answer all of those questions fully, so that an audiologist like Grant can say with confidence to a patient, this is your kind of hearing loss, this is what I'm recommending for you, and this is why I'm recommending it. I think that is something that we won't have the answers to straight away. But in the meantime, there are lots of different interventions that we can offer. Grant was saying one of the disadvantages is that it's a little bit trial and error. So some people find particular treatments help them. They might recommend it to a friend who tries it, who it might not work. So it's a bit variable at the moment.
So in terms of your work, Dirk, with neuromodulation, neurostimulation, this is quite long term. This is before we're likely to actually see these techniques.
Yeah, of course, because if Deb has already problems with hearing aids, which are being used for years, you can imagine how long it will take. And for neuromodulation also, there is another problem which complicates this kind of research, is that you're researching what is available now, and you have the results within a couple of years. But by that time, there will be new techniques, new methodologies, so you're actually always running a little bit behind. And that's another problem, because there might be something promising coming up, and then it will take another long time. So there is a difference between what is available and routinely used and being reimbursed by the state. So what is reimbursed by the state is basically one of the reasons why DEP does it. So the state knows better well how to use its resources. Also, it's better for the patients, because then they know, well, there is some evidence that what we use. But like I said before, research measures different things. On the one hand, it measures whether it is statistically significant. And this is interesting, because it just says, well, the effect is probably not due to chance, but to what you're really doing, to the treatment. But it's not because it's statistically significant that it is clinically relevant. Let's say you've got a tinnitus and you score it on a scale from 0 to 10, 0 it's not present, to 10 the loudest imaginable, and you score it 8. And you do a study on a large group of patients, and which is statistically significant, so the treatment that you provide, let's say a hearing aid, gives a benefit. But you see that that on total it goes from 8 to 7.5. This is clinically completely irrelevant. There's a little bit of a benefit, but it's not due to chance. But as a patient, you won't care, because if it goes from 8 to 7.5, you're not really it's not clinically relevant. So, and you always have to look at both aspects, and this is very, very important. Or you can have a treatment for a small subgroup, which can reduce the tinnitus from let's say 8 to 2, but it's an extremely rare form of tinnitus, and then it becomes difficult to find enough people who have it in order to be able to show statistically significance, because they're spread all over the world. So from a methodological point of view, there's quite a lot of practical problems, and we have to admit that we're always running behind.
And so you're saying there's quite a difference between what is significant from a research and from an epidemiological population-wide basis in terms of what the health service is going to fund. There's a difference between that level of significance and what might be significant for the individual. Those people for whom you do get an effect, it may be hugely significant, but there are only a very few of them, so they're not going to introduce it as a treatment in the publicly funded service. So,
yeah, that's true, but in some of the trials that we're running, we take that into account. So more and more we're interested in as researchers in how the benefit is perceived from individual patients' point of view. And if a treatment helps 50% of patients reduce their tinnitus symptoms to a degree that they're happy with, then that is useful information, I think, to tell our health service.
Right. Now, so then that leads on to the other thing. You've all been at the conference in Auckland over this past week. Given what we've talked about here, what are the most exciting things that for you each as individuals? What's the most exciting thing that came out of the conference in Auckland? What got you excited?
The thing for me coming to these TRI conferences, and the Auckland one was, again, no different, is the idea of a conference bringing lots of people together who work in very different disciplines. So this week I've been talking with ENT consultants, with audiologists, with neurosurgeons, and if we're going to solve this problem, we need all of the disciplines to work together collaboratively and collectively, and that's one of the great things about this meeting, is it brings all of these great minds from different disciplines all across the world into one room for 3 or 4 days, and we've had some really great ideas and discussions for further work. So I really enjoy collaborating with people in Auckland and elsewhere, and I think that's the way that we're going to make the most progress in our field.
Graham?
Yeah, well, I guess some of these things that when you go into a meeting, there are always advances, there are always new things, and some of it is an incremental improvement. You're always looking for the wow, that's an amazing sort of thing, but often these are happening, these meetings happen annually, so more often what you're seeing is incremental things. But what I think that we are, and it really relates to what Deb was saying, we are beginning to see where therapies aren't so based on the traditions of the researcher or their own philosophy, but pull in multidisciplinary efforts. So you might, for example, combine non-invasive brain stimulation with sound. So if you like, you're getting top-down as well as bottom-up information. You're combining that with understanding how the brain is working to target specific areas. We can also look at other disciplines where new or revisiting old techniques, for example within post-traumatic stress disorder, using hallucinogenic drugs not as an ongoing treatment but as a circuit breaker to try and change the way that people are thinking, but that has to be combined with psychological therapy, or it could be combined in a number of ways. So everybody would like a silver bullet, but the approach that probably we're really getting closer to is a silver shotgun, and that we're not very discreet in our targeting, where we're now looking to apply approach. Now, in doing that, hopefully we can bring it back and identify a couple of targets for our therapy rather than the whole brain or whole auditory system. But we're moving away from the miracle cure to understanding that there will not likely be any one miracle cure for everyone, but we have a number of very promising avenues, and it's about identifying how to pull these together and apply it for a given individual, and treating everybody that we see in front of us as a person that have their own circumstances, that have their own environment that they find themselves
Yes,
in.
you're talking about individualised, customised solutions depending on the individual. Dirk, what was the most exciting idea for you from the conference?
Well, we had actually Cliff Abraham was there, who's a basic scientist who gave a brilliant talk. And what was very interesting, so basically what he was explaining to us clinicians was how at the basic science level you can have changes that change the way the brain responds. So you do an intervention, this changes the brain, and then you modulate the brain, and so basically it's preparing the brain to be ready for the intervention, which is a little bit what Grant alluded to earlier on, like you give a hallucinogenic drug and then which prepares the brain for the psychotherapy, and then just the fact that you discuss together with basic scientists already gives you opportunity to discuss with them to understand why this could theoretically or practically work. Because otherwise, if somebody comes to you and says, well, we'll give this person ecstasy and that will cure his tinnitus, you're like, sounds strange. And the fact that you combine or have discussions with basic scientists that might say, well, definitely it won't work if you just give it, but if you prepare the brain for the intervention, whether it is neuromodulation, or whether it is psychotherapy, or whether it is auditory therapy, then you say, okay, but then we have to design the study in such a way that it maximizes the chances that something will come out. So the interactive discussions, what Deb alluded, taking it even further to basic scientists, allows you not to dismiss ideas as crazy on beforehand, but find a way of accepting this. And TRI was actually initially founded to explore even non-conventional treatments for tinnitus. And the idea of the founder was that traditional medicine goes way too slowly. So we have to be more open-minded. And this is why at these conferences there is always some, what we call weirdos, but maybe their ideas might be practically applicable, and we just have to understand why or why not, because it's very difficult. A genius in the right environment can blossom, but if he's in the wrong environment, he's considered just a wacko. So you have to bring people together that can say, well, this is really wacko, and we won't do anything with it, or, well, this might make sense. And that's why, as Deb has already alluded to, that's why you need these multidisciplinary groups, because then some scientists might say, well, yeah, it kind of makes sense because it just prepares the brain for an intervention, or, but then, based on the science, we have to use this kind of intervention. And so this is what is very stimulating about this kind of approach that is fairly unique in science in general, where you really bring together people from very different disciplines.
And this is the TRI, this is the Tinnitus Research Initiative that you're talking about.
Yep.
And that's you're saying this is quite unique in this area, in the area of tinnitus?
Not just in the area of tinnitus, and the whole of medicine is very unique, where you have such an open mind that as classical researchers you are confronted with people where actually you don't know whether they're completely crazy or whether they have a brilliant idea. And it's this confrontation which I think is very, very stimulating, but you also have to accept that some are just crazy.
So how long has this been running, and so what's the prognosis?
Well, it has been running for 8 years, so we've had eight, and it always has a different team. Like, for example, I organized it 2 years ago in Belgium, and then the theme was to confront artists, to bring in artists, to see whether art could, because they think about things in a different way. And so we had discussions between artists and basic scientists and clinicians to see whether, because they often look at the world from a different angle, whether that could be beneficial. We've had a meeting where there was predominantly a focus on the comparison of pain and tinnitus, so that we could benefit from what is known in pain, because phantom pain and phantom sound, the subcomponents, are mechanistically fairly similar. So where we would try to use whatever is known in phantom pain, because there's a lot more research in phantom pain and phantom sound, whether we could benefit. So it's always based on a different team, and we hope that this very open-minded approach will lead to different solution in a shorter time frame.
And so for the three of you, what have you got out of the TRI in the 8 years it's been running? How has it changed what you do?
Well, I think that one of the things is that in order to advance science, you know what you know as an individual, and through connections and networking, which Dirk was talking about, it can alter your perspective, or it can correct your view, or you can disagree with an individual, but it gives you arguments to try and create and provide evidence for. So the value is around sharing this information. It's about creating teams that can look at the same problem from many different angles and from very different philosophies to challenge and stimulate. So I think that's really that. It's looking at tinnitus, but from so many different angles that you as an individual sitting isolated anywhere, whether it be in New Zealand or in the UK, wouldn't be able to manage by yourself. So
Can you give us an example of something that you've changed in the way you do things as a result of this topic?
Well, one example is one research project that we're currently undertaking, where we are interested in the hearing side of things, but we've got vision scientists, because some of the training that we're using is visual, and we also have musculoskeletal experts, because we're bringing in somatosensory information. So this is something that an audiologist normally wouldn't go out. Somatosensory touch, tactile, yeah. So vibration, and because we know that for a lot of people, movement of the head or neck can modulate their tinnitus, and there's growing evidence, neurophysiological evidence, of why that should actually take place. So it's about forming multidisciplinary teams and being able to challenge convention and apply techniques that are not native to you in your particular training.
Deb, what difference made for you?
So I've not been involved in the TRI for the whole 8 years. I'm a relative newcomer, but one of the things that it has changed for us is introducing some of these more novel, innovative technologies. And through the TRI we've met some people who are working on these technologies and use our research expertise to set up trials to actually evaluate the benefit that these treatments can give. So one example of a study that we're just about finishing off, unfortunately not in time to present at this year's meeting, was a neuromodulation technique that has been developed in Germany, using sounds as the brain stimulators rather than electrical or magnetic energy. And this is a device that has now been built into something that is commercially available and has reached the UK market. So we've been been working with the German team who developed the device to see in a research study how beneficial it is, and to start measuring what's actually going on in people's brains when they're using this new kind of treatment.
And it's reached the UK market. How far is it from the New Zealand market?
Well, it's a small commercial clinic that offers hearing therapy and specialist tinnitus services based in London. And since they established a couple of years ago, they've expanded quite a lot across the UK market. And I think they probably have their eye overseas, but we shall wait and see.
Can you give us the names? I'm sure people will be interested to go home and Google it.
Well, if you Google the Tinnitus Clinic, that's the name of the centre based in the UK, and the device that we're actually looking at, it's a little bit of a mouthful. It's called acoustic coordinated reset neuromodulation.
Good. But what I'm picking from all this discussion, there seems to be a common thread through all of this, that we're really talking about brain training. We're not really talking about getting rid of sounds. We seem to mostly be talking about brain training. Is that really what tinnitus comes down to?
I think it's a combination of improving the input via the auditory system and changing what is sometimes called the maladaptive way of the brain responding to this lack of input. So it's coming from both sides at the same time. And this is relatively new because, for example, when I started being a surgeon, well, I only treated the brain. And then by going to these conferences, I said, well, maybe I should be open and start using hearing aids and masks and coordinated reset and phase out treatment, which didn't work. We tried it and it didn't work. So other neuromonics, other kinds of sound treatments. And then by going and talking to ENTs, I said, yeah, but we tried this medication. It sometimes works. So even strange medications. And so we incorporated that. So whereas in the beginning, if you only have a hammer, everything looks like a nail. So if you happen to have a magnetic stimulator, well, everybody gets a magnetic stimulation. So the fact that you go to these conferences allows you to have a broad toolkit, even though you have to realize that every single treatment might only have a success rate of, let's say, as low as 20%. Some don't work, so that's easy. Some work in 20% of the patients. The more of these you have, the more chances you have that something might work. Just like if you go to a pain physician and you have a headache, it's trial and error and people accept that well, some pain medication works better for one, so the fact that you've got these multidisciplinary meetings allows you to have a bigger toolkit that unfortunately still by trial and error you can suggest with some, even if it's very little, some indirect suggestion that it might be beneficial for some of the people. So this is very good, and what is correctly being found to be most likely the most promising avenue is the combination of hearing aids or strengthening auditory input and changing the way the brain responds in a not ideal way to this lack of input.
Cool. I'd like at this stage just to open it up to questions from the floor. If anybody has any questions they'd like to ask, we've got three of the best brains in the business sitting in front of us, so let's take advantage of it.
Thank you. When my husband received his hearing aids, he was told by the audiologist to wear them as often as possible because the hearing aids would actually retrain his brain. And if this is accurate, could you please say in what way hearing aids may be retraining the brain?
Okay, so if I first go at this, we know that, for example, just putting tinnitus aside for a moment, that there's strong evidence that if people have a hearing loss and they delay getting hearing aids, right, that cognitively, how they use their brain, they are behind their peers who have hearing loss and actually have hearing aids. So in many ways, by stimulating the brain with auditory information is not too different from going and being busy in your environment, exercising and so on. The brain is receiving information. If it doesn't receive information, it gets bored. All right? So from a very simple perspective, if we talk about retraining the brain, well, we're keeping the brain active. If we bring in the tinnitus perspective, then what the theory there is that if you have sound competing with the tinnitus, over time the brain will spend less time focusing on the tinnitus and will broaden its perspective to incorporate other sounds. So that's a form of training. Right? It's a passive training. It's what we do as a young child when we're moving around our environment, understanding what things make what sounds. If we tap something, it makes a novel sound. The brain learns that. If we have a hearing loss, we begin to unlearn some of that information. We're about putting it back. A classic or an easy demonstratable example of this is with cochlear implants. Right? So these are the bionic ear. Now, if you have a child who's deaf from birth, if you implant the child with a cochlear implant before they're 6 months old, they will fairly much gather language at the same rate as children of the same rate. So when they're at school, they're exactly the same language capability as their peers. If they are implanted at 5 years of age, they will probably never develop speech in a usable form. They will always be reliant on sign language, okay? Because although we talk about the brain being able to adapt and be trained, there's a certain period at the moment that's critical for developing that information. So that's another example of training just by being exposed to sound. Yeah.
Stand up because I've been sitting down for 20 minutes. I have tinnitus and hyperacusis as a result of a traffic accident. The tinnitus I'm managing by a cute little sound device in my ear. The hyperacusis is severely restricting the number of noise environments I can go into. I understand that hyperacusis and tinnitus usually go together when there's been a head injury. And what I've not been able to find out is, are the two interrelated or are they sort of parallel pathways? And I think this is important for me to try and work out whether trying to find out ways to help one is going to help the other, or are they separate? Does that make sense?
Do you want to? Yeah.
Well, from a mechanistic point of view, first of all, many tinnitus patients also have hyperacusis. There is patients who have hyperacusis without tinnitus, but that's rare. There is very little research that has been done on hyperacusis. Last year there was only like about 300 papers on the mechanisms of it. One of the hypotheses is that when you develop hearing loss, as I mentioned before, your brain tries to still obtain the information from the environment, so it will increase its gain, its sensitivity to pick up, and that might be hyperacusis. And then when it fills it in, if it can't get it, then you get tinnitus. So they're probably both linked to deafferentation. Now deafferentation is a lack of input, but that does not mean hearing loss. You can be deafferented without having hearing loss because your hair cells, they overlap, so you can have a loss of a little bit hair cells, but because of the overlap, the brain can still pick up the information. Now, if you have this, so they are interrelated, but the interrelation is probably indirect via the lack of input. Strangely enough, you can have a differential effect on tinnitus and hyperacusis. For example, as a surgeon, I sometimes remove blood vessels that tap on the nerve and that create tinnitus, and sometimes you see that only the hyperacusis goes away, but not the tinnitus, or the other way around. So they are, even though they're interrelated from a treatment point of view, they can respond in a differential way to medication. We will, if we give medication, we will try different medication for hyperacusis than we will try for tinnitus. So even though we think that mechanistically they come from the hearing loss or the deafferentation, they are kind of separate mechanisms.
From a clinical point of view, related to what you were saying, now what would we do to help the tinnitus when a person had hyperacusis? From an audiological perspective, we would probably manage them in a very similar way in the way that you're being managed with hearing devices. One of the things I would say though, it's easier to notice a quicker effect with tinnitus simply because of the contrast effect. So with the hearing aids out, putting them in, that can change the perception of the tinnitus. The longer term change in tinnitus and the less sensitivity to sound tends to be a more gradual process. So it will take longer than the effect that can be pretty quick when actually fitting hearing aids for the tinnitus.
Lady here in the red one.
Is there any work being done on the relationship between depression and tinnitus? Clinical depression?
I can answer that question from a research point of view. Yes, there are quite a few population studies that have already been done on the association between depression and tinnitus. So there is a higher level of mental health conditions, primarily anxiety and depression in people with tinnitus, but only a smaller number, and certainly psychiatric or clinical depression, the very severe depression. I think what is thought is that tendency or the clinical depression is already there before the onset of the tinnitus, and it might not necessarily kind of be triggering it. But it's I think you've already got a sense from today's discussion is that tinnitus is a very complex and challenging problem. Although it is primarily a hearing problem, there's a very close linkage between the people's emotions to the sounds and their general emotional and mental health well-being, and the way that they react to the tinnitus and interpret the tinnitus. So these two things are very intimately linked, and I think effective treatments are going to be that combination where the clinician looks not just at the hearing loss and the hearing problem, but also deals with the way that the person interprets the sound and how it impacts on them generally.
Perhaps I could give an example to this. In thinking about the same solution applied to one person versus another, music is often used as an assistive therapy, a sound therapy for tinnitus, and obviously we have strong emotional connections with different sounds irrespective of tinnitus. So there's a connection between sound already and how we feel about it. But in a study that we did, we found a particular piece of music was favoured by the majority of people for their tinnitus. It would seem to be the winner, if you like, except for one person for whom that piece of music was played at their father's funeral. Okay, so there's the same piece of music, but it has a different emotional context for it, so it will have a different effect on the individual, not because of the sound aspect of it, but because of this emotional context and framework within which it's placed.
Thank you. I think we've got time for one more question.
A number of the issues here touched on but not dealt with in detail. Is this on?
Yep.
The issue of different types of memory. long-term with neurological connections, short-term, very short-term electrical currents, medium-term changed thresholds, neural thresholds. Now, the treatment of tinnitus seem to be largely related to the shorter-term versions of this, but are not making it through to the long-term neural connections in the brain, which presumably are significant in establishing whether or not tinnitus becomes a big feature. This kind of research, of course, has much more extensive implications, and my understanding is that the traditional classical view of the process in which various images and ideas get stored in long term, it is going through a revision. Could one or other of the panel members elaborate on what the current status of memory research in this regard is?
Well, we've been very interested in this link between auditory memory filling in the missing information. One of the reasons is that, like I said, initially we thought, well, it's very simple, tinnitus will be solved within 2 years, we just put an electrode on the auditory cortex and we get rid of it. And then we saw it was not like that. So what we did is we looked at a couple of patients who were implanted, who benefited from it, versus those who did not benefit from it. And what we saw is actually that the posterior parahippocampal area, which is the entry and exit of auditory memory, was the difference between the responders and the non-responders, which we could not explain because the problem was that the electrode is on the auditory cortex, but whether or not you were going to respond depended on your parahippocampal activity. And then we looked at the connectivity between them, and what we saw is that only those who had a good connection between the cortex and the parahippocampus were the ones who were benefiting. And these were also all the patients who had a hearing loss in the same frequency as their tinnitus. So this forced us to start thinking about, this is strange, because actually we had 50% of the patients who responded to the implant with the wrong theory. But we were lucky that there were, in some of those patients, there were these connections. So it's so you can imagine that in the future, whether or not you're going to be helped or not by a treatment will depend on a couple of things. First of all, on what is the connection between the area that we want to modulate in memory, auditory memory. It's predominantly the posterior parahippocampal area, and how do we get there in the best way? That you might need imaging that not just looks at the area itself, but also what is the best connection that we can use. And then once we start getting there, then we can start studying this auditory memory. And so what we just presented in Auckland was very preliminary data showing that, for example, in tinnitus patients, the communication, how is the communication between this parahippocampal memory area and the cortex? Does it go from the cortex to the parahippocampus? And it seems like that. So it seems that if you have hearing loss, basically your auditory cortex just goes signals to the parahippocampus saying something is not arriving. And then the more that is not arriving, the more the parahippocampus might be sending back to the auditory cortex. But what it sends back is what is last stored, which might be actually the tinnitus sound. And so in order to study that, you look at how some waves carry the information, just like in a radio system, to the auditory cortex. So this interaction, this communication is indeed very important, and we see that more and more research will be conducted to that. So it's a very good point you make, and this is also what at least our group is looking at, and other groups are starting to look at as well.
Thank you.
Can I just add a quick additional point as well? what we know about sensory memory is that it's quite distributed. So if you imagine hearing a sound, then it's been shown that memory of the sound also engages your auditory brain, the same areas that would actually process listening to the sound if that sound was really present. So some of the neuromodulation treatments, and particularly the acoustic neuromodulation treatment that we've been working with, does aim to bring about some long-term permanent changes in tinnitus by stimulating the auditory parts of the brain. You're not just stimulating those regions that deal with input of external sound, but you're also changing the way that the memory of sound is encoded. So that's one of the mechanisms by which some of the more acoustic kind of treatments are suggested to be beneficial.
Well, thank you very much, team. That's a fascinating discussion, and I mean, it's clear there's a lot more work to do, but it's interesting to hear that whole development in the area of brain, neuroscience, and where it's going. Certainly changed my view on a number of things. But so I'll just ask everybody to show their appreciation for that discussion. Thank you very much.
Here. Thank you so much, and a small presentation for you from us all with many thanks. Grant.
Thank you.
And Deb.
Thank you.
And Alan. Wonderful, thank you. Now we have a short break. The Museum Cafe is open, and please join us again at 1:30 for the next discussion. Thank you.
Thank you. Chair.